put it in, we put that model in a different setting with different data. We can
Okay, guys, let's give Jada a moment.
because some are a lot better than others. So there are lots of different ways to test models. One of them is benchmarking. You might see that mentioned. What that means is that you have a labeled data set, which is considered a gold standard. We know that all the labels in it are right. So when we put our model on the same data set, we want to see those same labels being called. Or we have maybe some clinical notes and we know what the diagnosis should be. So we want to see that our model is picking up on those correct diagnoses. Some of the model types that we might talk about, machine learning models. Machine learning is a sort of older branch of AI, but still AI. That includes things like regression models that predict risk. So I might be able to, for example, predict somebody's risk of a heart attack based on their lab test results, for example. And I can also maybe model things like the
Sorry, I don't think we're sharing screen anymore.
Oh, okay. Yeah. Do you see my screen?
Yes, we can see now.
You do? Okay, sorry about that. Generative AI, LLMs, large language models are things like Claude or ChatGPT. They're models that we talk to. So they can do things like write reports for us. They can send reminders. You often find them in chatbots. So, for example, making medical appointments. You might have chatbots that answer advice. Often you'll find them in mobile phone apps, for example. An important thing to remember with LLMs is that they need to be guardrailed in medical context. So what that means is we have to be careful what they say. They can't just be allowed to make diagnosis for people, for example, without supervision. They need to be told, for example, to advise a patient to go and seek proper professional advice for medical things. They shouldn't be necessarily dispensing advice which might be subjective. Another type of model that you might see would be NER models. They find things in free text and they label them. So, for example, we might ask it to find out whether someone's been taking their prescription, because we may have in a table that a prescription has been given, but actually the most useful information might be in their diagnosis notes. Or often we find that patients only have free text notes, so they might just have, for example, an appointment book. And going through that text and pulling out interesting things is a job for NER models. The other type of models that you might see embedded in apps and tools would be OCR models. They read in paper notes, and there are also voice-to-text models that you can talk to. For example, you might talk to a smartwatch, and it will take your speech and turn it into text inside that app. Now, the other thing that you will see in papers, including AI models, is an assessment of how well that model performed. And I won't go too much into the detail of this here, but I will share my slides afterwards if you're interested in this. So this is an interesting quote from a few years ago, that 80% of AI projects fail. And that is because they haven't really been assessed in the right way. And they've been sort of promoted as successful tools and models, but actually they haven't really been evaluated robustly. So accuracy, I think, is probably the number one thing that we would think of that we would want a model to be. That means that it spots something if it's real. It identifies a risk. It will tell you the right answer. But it's also really important that models are specific. So if you have a model that gives you an alert and an alarm very, very regularly, quickly you will start to ignore it. So for example, it might be something like if you imagine a fire alarm in your house. And the fire alarm, it goes off when there's a fire, but it also goes off a few times a week because it is just oversensitive. Eventually, you will probably unplug the fire alarm because it goes off so many times that it just becomes a nuisance. So that's the sort of model behavior that can be unwelcome. So we want to make sure that specificity is there as well. And when we report accuracy, it's important to remember that unless it's had tests in different environments, it might not be as accurate. So you'll often see something called F1. F1 is a mixture of the accuracy that we want with recall, which is complete capture. So it's precise, it's going to recover only correct events, but it's also going to recover all of them. So it's a measure of both of those things, which is why F1 is so important. And if you only assess with one metric, I would choose F1. You'll also see different measures for different types of job. So if it's a ranking job, you might see RAC, AUC. If it's predicting how much of something or predicting a number, you might see MAE or RMSE. And then if you're asking it to put something into a category, you might see something about classification performance. All of these can potentially be important, but I would say that F1 is particularly important. And if you have papers that don't really report any of them and you feel don't really evaluate well whether something is accurate in different settings, then it might be that you should be more suspicious about using that type of model. There are so many models out there. I would use quite a reputable model that you know has been used in other studies and has had good results, because there are so many models out there, it doesn't necessarily make sense to create a new one if you don't need to. Although you may find that there isn't a suitable model for the type of data that you have or the setting that you have, so you may wish to do that anyway. These are just some things that I would watch out for if I was reviewing a paper involving AI. Again, if there's no external testing in different types of data sets and no testing against benchmark data, if they've only used there's a small training data set, maybe there are some issues about balance in the data and the data that they used. Maybe they didn't have much to work with. That's often a problem, actually, that you want to model something, but there's not much data that's already been collected. So you may have to build a model that you know is imperfect, which will be improved over time. So it is really important to keep retesting models. So hopefully if you're reading a study, they will talk about retesting models over time. Also, if it's too good to be true and the accuracy is really high, it's sort of promoted as the most accurate model in something that there's ever been, these type of claims usually sort of mean that you should be a little bit more suspicious, because most research organizations publishing their models will be a bit more cautious about what they are claiming. There are good quality frameworks for good practice that people can follow, like tripod and consort. You can talk about failure cases, a paper that discusses the limitation.
Excuse me, Hilda. I think there is a question on the chat box, and
okay.
since your
I can't
camera
see
is
that.
off, also.
Oh, my camera is off. Can you see me now?
Yes, can.
Let's open the chat. Here's the question. Yeah, that's a very good question about F1. How do we find a balance between precision and recall? Because increasing one often reduces the other. So F1 is a harmonious mean. So it penalizes things that are outlying. So if you had a very extreme low precision or very extreme recall, you would still get a low F1. But it isn't what end of the spectrum your model is on. So it can depend on the circumstances what's acceptable. For example, if you have something like an oncology model and you're looking at identifying tumors, you might not mind that there's a lot of false positives because the priority for you is probably that you catch all of the cases. Whereas if you're looking at something like high blood pressure, where perhaps it's going to be a nuisance that it keeps alarming for patients probably that have chronic high blood pressure, you might want to calibrate your model, and it might be more important that it has more specificity. So it really depends on the context, what's acceptable. Okay, I will carry on. Do you see my screen still?
Yes.
Okay. So we'll move on to talking about research pathways and doing our own research with AI. So like most studies, it's really important to have a question that we can answer with a good framework. So what does it look like for our research to be successful? How much time have we got? Is it answerable in the time frame that resampling or some bootstrapping if we don't have sufficient data? There are open data resources that I think are good to explore. Interested in building your own models. So it's good to understand what's out there already. And to choose a model that works with the question. So I would say, the simpler we can make the question, the better, while we're still trying to make something novel that would be interesting in a research context, because it's easier to defend a simple question and also to use a simple model if we don't need to use a more complex one. Validation is important, so we need to make sure we don't use all of our data when we're building a model and we leave some for validation. And the way that we split that is important. So for example, if I've got a year's worth of data and I have patients coming and going in that data set, I don't necessarily want to split it by time. I want to maybe split out my patients within that data set. And we need to talk about how we will report the data. So already be planning how we're going to publish the data, what we're going to share, so that we can make that study reproducible, which adds credibility to it. Maybe we're going to share our model, or we're going to share a lot of detail about how we produced it and how we're going to monitor it and retrain it in the future as well. So what is the difference between an idea and a full research project? It's really sort of reframing our question. So you might have a question, maybe you work with sepsis, for example, and you're interested if you can use AI tools to help you identify sepsis earlier before those patients become more severe. That's quite a vague question. So we need to add things like a time frame, an endpoint, and how we are actually going to address and build a model. So here's an example of that question. In adult inpatients, so you've defined your population, can we make a model using routine vitals and labs, so data that we already are collecting? Can we predict sepsis 6 hours before we typically can? So that's a target that we either meet or don't meet. So it's a very clear outcome. And will that give us better sensitivity than our current early warning score? So it's going to be very pass or fail this test. I wanted to share with you some resources for existing models, and I think that's really important because it's very daunting to come into AI thinking I now need to build myself a clinical model. There are many models available at different places without cost. So Hugging Face is one of those resources. They have, you can see they have 2 million models, nearly 3 million models that you can access. And there are some very notable clinical models, like the BERT family of models that can be accessed that are already trained on clinical data. So some of them are trained on things like PubMed publications. Some of them are trained on large clinical data sets in places like Mayo Clinic, Cerner data, for example. What you would ideally be looking for is something that's been trained on the type of data that you're interested in. So maybe you're interested in chest x-rays. You'd be looking for models that have already been trained on chest x-ray data to use as a basis. We can then add to these models. We can add what we call layers onto models. So models might already have different labels for different things. So they have some knowledge already ingrained. So when you add on another layer, you're basically just feeding it more information, more context that's specific to the task that you're going to ask it for. So maybe you have a model that's already been trained on chest x-rays, and it's been trained to look for one specific condition, but you would quite like to use it for another. So adding in that extra layer of information is part of that training process. That means that you don't need to build a whole extra model. There's also OpenRouter, which is a way of accessing many of the more general models with an API call. This means that you can integrate them into your own apps and tools. And it also means that you're not having to host them. Some of these models are very large. And if you have restrictions around computing, you may want to go down this route of using API calls to models. Especially if you are using a tool that is going to do something like make a chatbot, or it's going to maybe read through large amounts of data. So it might not even need to be medically trained to be able to do the task that you're asking it to do. You're just asking it in a medical context. So I would recommend also OpenRouter for that. And this is a table that was constructed a few years ago. Things have moved on substantially, so I wouldn't get too fixated on specific models because the best models for clinical data change all the time, and everybody has their own opinion on which are best to use. But I just wanted to show you that the BioBERT, which was considered one of the best models a few years ago, it does really well in finding things in free text. But it's notable that actually some of these things it's not very good at. So it's not good, for example, at looking at big tables in EHR datasets. And if you ask it to write you sentences, it's quite bad at that. That's because it's really been trained just to find things. Then you have things like PubMed GPT. It's a GPT model, so it's very good at writing sentences and telling you things about conditions if you ask it questions. For example, you can ask it to tell you all about kidney disease, and it will give you a nice essay on that. It's not very good at looking in tables again. So whereas you have something like MedBERT, which has been trained on tables, it's very good at that, but it's not very good at writing sentences. So depending on what you want it for, there's always going to be different choices that work well. And I think maybe just spending some time looking at what's out there and choosing the right model will save you a lot of time later on in your study. So looking at telemedicine, I think telemedicine is something that has, a natural application in Africa. you have a very large geographical space with a lot of remote regions that benefit hugely potentially from remote medicine. What dictates who has access to remote medicine is another question. But there's definitely potential, and you can see very easily that there is a great potential for telemedicine to assist. So there can be very high ratios of patients per doctor, especially in sub-Saharan Africa, but many people don't have any interaction whatsoever with healthcare. These are the people that probably benefit the most from telemedicine potentially, and remote diagnostic apps as well. Most of the African population has some access to a mobile phone, even if that's shared, but it's not always a smartphone. Some of them are lower tech phones, so that's important to remember. And many people have to travel for hours to get to any kind of clinic, particularly further if they need to go and see a specialist. So what models can do potentially is support by reducing the amount of time taken to connect with the right type of specialist, especially if you're having to take a journey to get to that location. You want to make sure that the specialist that you need is going to be there, that the clinic will be open, that they'll be able to see you on that day potentially. So being able to give that information in advance can be so hugely beneficial. South Africa, Kenya and Nigeria are big early adopters of telemedicine, by which I mean sort of video and phone call interaction with doctors in real time. So some use cases are already in place, some are quite well established, and some are up and coming. Things like diagnostic apps via the phone, which will do things like use a phone camera to screen for eye issues, also for skin diseases, which can be quite easily distinguished from one another by AI models. Also, triage and teleconsultation. I think triage apps have been very popular from the beginning because there is such a high burden on a lot of clinics and health providers. Having triage models in place to be able to redirect people to the correct specialists and doctors, to be able to distinguish severity in patients, that's always been, I think, very high on the wish list for a lot of providers. Telemedicine also has a role in reducing pressure on in-person services, which is important. There's also a role for AI tools in public health messaging. So predicting disease spread, predicting, for example, context in which there's likely to be high risk of exposure, reaching communities about sort of ongoing outbreaks of different infectious disease. All of these things can help, as well as sort of promoting public service messages where those are needed. But there are some things that hold back the rollout of some apps and tools. There can be connectivity issues, especially in remote communities where some of these apps would otherwise have the most benefit. So it's important that tools are designed in a way that they are still usable when users are offline, for example. A lot of the machine learning models and AI models are trained on data that isn't from a local context. So it's important to check that they are actually performing as expected and not just assume that they can be rolled out and that they will work as we want them to. There are going to be differences in different sites in what devices are available, whether those are smartphones or whether those are lower tech phones. There is a lot of demand for things like apps that are based on WhatsApp. And that's because most people's phones will support WhatsApp when they won't necessarily support higher tech apps, for example. There is an issue around liability, consent, data sharing. In a lot of cases, data sharing legislation is still catching up with rollout of AI tools. It's not obvious immediately who's at fault if something goes wrong. Is it the person that trained the model? Is it the app provider? How much liability is with the patient to understand that they may need a second opinion other than what an app or a tool is telling them, for example. And it's still the case really that models should support clinicians and they should not replace them. But in the context of some of these remote apps and tools, it may be the only interaction with medical advice that that person is having. Here are some examples of tools that are already rolled out. And they sort of illustrate the different types of technology that is currently widely available. So this is from a company called Peak Vision. This is a retinal imaging tool, and it's designed to look at diabetic retinopathy and a few other different eye diseases. Peak also provide an eye test tool so that you can do an eye test without needing to go to an optician, for example. So there are tools that are pretty useful for both clinicians and patients potentially in their suite of tools. There are things like this public health information tool, which was designed during the COVID period to give people information about COVID numbers near them, how they can access resources. If they have concerns or they want to see a doctor, they could use this app. So this sort of public health app is also one of the sort of key areas of rollout. This one is for TB screening. This is more of an app to be used by a doctor, and it's used in this case with a stethoscope. So there are tools that are specifically for doctors to use in the field to increase their capacity to do diagnostics remote from the clinic, for example. And then we have things like clinical scribes. So Heidi now has a presence in South Africa. Heidi as a clinical tool, I think clinical tools are an interesting example of how we often evaluate AI after it's deployed. So clinical scribes are very good at reducing the time that a doctor needs to spend typing in or writing down notes during consultation. But sort of more recent feedback from doctors sort of highlights another problem, which is that at the beginning of a consultation, doctors are often reading notes as well. So while they will often write quick shorthand notes to themselves, Heidi writes very extensive full notes. So actually a lot of the time that they're saving and allows them to be with the patient more, it's taking a little bit more time to then come back and review and read those notes. So there's always sort of an understanding of the doctor's experience or the patient's experience, whoever's the primary user. Understanding the way that they use and interact with a tool is really important to understanding actually how useful it is. So I wanted to talk a little bit about an example where that didn't go well. Babylon AI was a very sort of popular touted tool at the time. It launched with a very high valuation. It launched initially in Europe, and then they began to rapidly scale and get bigger. The whole point of the tool, which they call the AI symptom checker, was that it would triage patients based on their symptoms, and it would tell them whether they should use a sort of telemedicine service, they should go to a clinic, whether they needed immediately to go to the hospital, for example. And it proved very successful in European settings, but because they had a very high valuation, they also had a lot of pressure from investors to rapidly grow, to sort of cover all disease areas in all locations. And that led to them not understanding very well new landscapes and new health areas that they were entering. Their focus was on sort of rapidly simplifying healthcare, beating benchmarks with clinicians, for example. And they had a case in Rwanda where there was an outbreak of dengue fever, and the device performed very poorly because it was trained on Western data. There were symptoms like headache and fever, which were emerging, which in the context of the location should have been flagged as being worrisome for dengue fever, which was expanding at the time. But those patients were dismissed as probably having influenza or heat stroke or maybe meningitis, which would have made sense in a European context. So that did lead to loss of confidence in the products in Rwanda. and they did withdraw their services in 2023. They were able to later rebrand and enter the European market again. So I think, with a refocus and an understanding of the limitations of what they were doing, they were able to redeploy and recreate that company in a way that made sense. But it sort of highlights how important setting and context are in deploying AI models in healthcare, especially training adequately with the right type of data. And also that the patient needs to be listened to, the clinicians need to be listened to. There needs to be an ongoing dialogue to understand whether that outcome and that advice is being relevant. And it sort of reinforces this idea that it is a clinician's helper. It's not a replacement for a clinician. I'll just stop and check that there's nothing in the chat here. Do you have some new questions? I think there might be some problems with the sound. Sorry if you've had problems with the sound, but we will keep going. Yes, this is a good question.
Okay.
You hear me? Okay, that's good. When we're looking at existing models for disease condition, can we lay an African-centered data set on that? I think we can, but with caution. So what I would suggest is taking part of your data set and labeling it, and using that as an instruction to fine-tune your model, and then potentially deploying it and testing it. But I think it's important to have a sort of calibration with already screened data if you're deploying into a new environment and with new patients. For example, a good example would be, for example, during the COVID epidemic in the US, there was poor treatment essentially of African American patients because the equipment being used, for example, pulse oximeters, performed poorly when they were looking at things like skin tone, and they were relying on that oxygen saturation. So there are some things I would say, particularly sort of visual apps, that need to be calibrated really well to make sure that they're serving everybody. And I don't think that we can assume that models have been trained in an inclusive way, looking at a variety of ethnicities of patients, looking at different health contexts, for example. Like, we would like to assume that models have been trained with infectious disease in mind, but we can't assume that. So I think even if you're looking at two hospitals in a similar area and you want to transfer a model trained in one, we should always sort of check its performance before we're deploying that properly. Let's see if it's... Okay, I'm going to continue, I think. Oh, okay. What is more accurate? Regression machine learning models like scikit-learn or TensorFlow, or using LLMs, especially in disease detection. So I would say that LLMs are better for generating text or for searching large bodies of text. Machine learning models, I would say you already have to give them either structured data in tables or sort of labeled data. So it really depends on the data types that you've got. If you've got lots and lots of pages of clinical notes, I would look at using LLMs. You can potentially use them in combination. You can use an LLM to extract your data that you then use to build your machine learning model, for example. How can we optimize performance in prevention of disease and predictive models? It's a good question. I think one of the things that needs to be done foundationally is building decent data sets that are actually collecting the data that we need. And I think some NGOs are starting to show interest in developing benchmarking data sets and funding that. it is important to have a good data basis, and I think that is one way that we can really move forward with that. To select a model that is best suited, I would say if you look at a model that has already been trained on that data type or that type of task, there is always more than one good choice. There's never just one good choice of model. And I would say maybe test out multiple models to see what their performance is with a small sample of your data, or a similar task maybe. Okay, I think that's the bottom of the questions. I'm going to continue for a bit and then I will come back to the questions. So I work quite extensively in wearables, particularly in women's health. There are two types of wearables really that I think are most interesting. One is the wearable where the primary person using it is the patient or the consumer, and they're using it because they're proactively looking into their own health. For example, they might be interested in their heart rate. They might be interested in things like their hormone levels. The other branch of wearables would be that a doctor has prescribed that either to remotely monitor a patient that's not in the ward, or to monitor a patient, for example, during surgery. Like maybe they have a portable blood pressure monitor that they're wearing continuously, for example. So these wearable devices are increasingly being augmented by AI and machine learning models in linked apps or linked software. They collect a lot of data, wearables, and they're very noisy. And understanding how to process that collected data into something that we can act on, that is something that is a really good use case for AI and machine learning models. So the types of things that they might be sensing would be things like your heart rate and rhythm, how saturated your blood is with oxygen, your blood glucose, for example. A lot of diabetics now wear continuous blood glucose monitors. Your level of movement and exercise and your sleep, things like your skin temperature and impedance, which is like the electrical current across your skin. And that data is all picked up and it's sent in a number of ways to devices and receivers. So in a hospital context, that might be something like Bluetooth, connecting to a Bluetooth hub, which is plugged into the wall. It might, for example, have like a cellular chip in. Some of the most recent ones have SIM cards in, so that they can broadcast straight to the cloud without the need for a middle device. In areas where connectivity is quite low, it's important that a device can have a big memory and cache a lot of data, so that when it can make a connection to the internet to upload its data, it can push that data and it doesn't have to lose any of that in the interim. There's an interpretation layer for this data. So when I collect maybe 6 or 8 hours of patient data through a wearable device, it gives me a huge number of data points, because maybe the device is collecting data every few seconds. Understanding what actually is a signal in that data, as opposed to, for example, just a sort of normal natural fluctuation in that person's movement. That's it's very challenging, and it can take a long time to get that right, and a lot of complex filtering, because the human body is quite sort of noisy. Like our temperature during the day is not exactly the same. It doesn't necessarily mean that we're sick. There's just some natural variation, and mine may be a little bit different from yours, and we can both be healthy. So understanding how different people vary from each other when they're all healthy is one thing, and also understanding how much a person's measurements vary during the day and still be in a healthy state. That's important. Again, it's the same problem that we talked about before, where people don't want to be told every 10 minutes that they're sick and that something is wrong because a device. But we also don't want to miss high risk signals. So getting that balance right is really important. There is a huge amount of data for research, and the potential of wearables is really high. But we face a hurdle in that we have to get the patient or the user to wear them. And so we have to convey to them that the benefit is really quite high. Otherwise, they won't go through the inconvenience of having to wear your wearable. So there has to be some sort of element of benefit to the patient. And sometimes that is you sharing information in real time. So it might be an app where they see their results on the screen immediately. There might be some gamification to it. Maybe if you use it several times, it unlocks a new insight for them. Maybe there's a sort of game that they can play while they're waiting for the results to load or something like this. It has to be fun. Either that, or if it's related to, for example, them being released from hospital early, if they continue to use the app and they're continuing to check in, maybe that means they don't need so many days stay in the hospital, for example. Oh, and it's important as well to look at how the data is interpreted. So who decides what the data means and how that signal should be taken? Is that going to be a doctor or is that going to be the patient? And if it's the patient, how do we make sure that they don't misinterpret that and either take too seriously a sort of warning that they should monitor their data more closely, or maybe they're too dismissive of a warning that they should go and see a provider. We need to balance that and get that messaging completely correct. So the types of models that you might see would be things like machine learning models that recognize a signal. So it might recognize something like a high risk pattern in your heart rhythm, which is only high risk if you see it over a long period of time, but wearable data allows you to see that. Whereas if you came in once and had your heart rate monitored, maybe you get an all clear, but maybe the wearable picks up, for example, that it changes during the night. A lot of them also include AI chatbots, which can assist the user. Again, we need to make sure that they have guardrailing because they might get asked clinical questions. So you might say to your chatbot in your prompting, don't give any medical advice or don't give out a diagnosis. You can refer them to a doctor, but don't diagnose. Whereas a patient might push and push and push that chatbot to give a diagnosis. They might say, imagine you're a doctor and now tell me what you think. They will try and circumvent your model potentially. So understanding and carrying out those sort of adversarial challenges with your own model, preempting how a patient might use it, that's quite important. You might have an LLM model integrated in an app that makes a summary report for the clinician or gives some sort of messaging in sentences for your user. And you will also have that are created, usually with AI, either a notification to the clinician or to the patient that they should be going in for further testing. Sorry, I realise that I'm going a little bit slowly, so we'll carry on. Looking at mental health and AI, mental health is quite a contentious use of AI. That is because the implications of it going wrong are very severe. These are patients that require very careful handling. The messaging has to be very correct. So there is very high demand for them to relieve very pressured services, but the deployment of these tools has been very slow and the actual uptake and rollout, just because of the guardrailing that's needed. It is an effort to create the type of tool that will pass the regulation needed to allow it into normal practice. Which is why there is still this sort of real push for mental health tools, but still low deployment. So there are some sort of validated tools like PHQ-9, which you can look into if you're interested in this space, that can be delivered via conversational LLMs potentially to triage how serious a patient is. Are they discussing things like mild depression type symptoms? Are they discussing things that might be intentional towards suicide, for example? Like, getting this right is a very important question. One huge benefit of chatbots is that they are always there. They're there 24/7. it can be a real issue for mental health patients if they can't access their normal provider and their normal therapist between their appointments. So it does help to safeguard patients between those events. Also, there can be minor things that people say that can be surfaced with an AI model. So maybe something that happened during the session that wasn't immediately picked up, but could be a red flag in combination with other things. There are non-negotiable guardrails we have to put in that if self-harm is mentioned or a crisis, it should be escalated to a person every time. We have to make really clear to mental health users regularly that they're talking to a tool, an AI tool, a bot. They're not talking to a real person, because that boundary with reality and a parasocial relationship can be very thin. We have to prioritize, obviously, patient safety and how we handle the data before we can't sort of engagement with an app like we normally would do with a clinical app, where we try and get people to use it as much as possible. That is not the goal with a mental health app. We need to make sure we validate it with real users in that context, and not just assume that the model will transfer. So what we need from tools as they're developed, ideally, especially I think in an African context rather than a European context where tools might sort of be more developed more frequently, is that they're co-created with the communities that they're going to be deployed in, particularly communities with those specific mental health disorders, and especially trauma-induced type mental health crises. They might need specific context to understand them. And so communities should be consulted, and end users should always be consulted in tool creation to understand what's actually needed and what is not helpful. There should be multilingual support, especially in regions where there are a lot of different standard languages. For example, many Indigenous groups using different ways of communicating. A tool is only as good as, its usefulness to people. It does need to be multilingual. It needs to bring more people under a mental health umbrella, not exclude additional people. It needs to be ethically governed. So who's benefiting of this app? Who's paying for it? Who's setting it? Who's making sure that it's still functioning properly? Type exercise. It needs to be continually evaluated for its use, because of the importance of the importance of the conditions that it's supporting. And there needs to be empathy for the patient experience. So it shouldn't all be about reducing waiting times and reducing pressure on services. It should be how do we relieve the suffering of mental health crises? So some examples would be ChatCare. ChatCare is an AI chatbot from the Kenyan Red Cross. The reasons why I think it's successful: it's a very simple app. It's text-based. You can access it with WhatsApp. You don't need an advanced technology phone to be able to use it, and it's free to use. It's available 24/7, which is really important. And I think that because it's from the Red Cross, it is more trusted. So you don't need to write any code for many of these. If you're just data analysis, for example, write formulas in so that you can add sort of mathematical equations to them and build models. There are also things for like Claude, also apps like Lovable for things like website and mobile app building. If you're interested in something that's more of a chatbot,
it's that your screen is not being shared and your camera is off.
Oh, I'm not sure why that keeps happening. Sorry.
Sorry.
That's okay. Oh. How about now? Are you with me again?
Try sharing.
No? Try again. Oh. Share. How about now?
Yeah.
You see it now?
Yeah.
Okay, great. So I would say that creating chatbots is probably the easiest thing to do without code, or creating websites and sort of information type mobile app. There are a number of different tools to do this out there that have free tiers. So I would definitely explore that as much as possible. You can do things like automating processes. If you're interested in something to help you within clinic, or just sort of reducing the admin burden medically, I would consider using something like N8N. It has many existing automation tools that other people have built that you're able to adapt. You don't need to be someone that codes to use this. So if you want something that automates something like sending appointment emails or writing up medical reports, this is the type of place to look. Dashboards can be really useful in things like resource management for NGOs, for example. If you're a busy hospital, you have limited staff resources, maybe you have like waiting lists to manage. A dashboard can help you see quickly like where problems are emerging, where you might have free resources that you can deploy to other places, maybe how much departments are spending, that type of thing. If you're interested in learning to make models but you don't want to code, you can use something like Google AutoML, which I think is useful for sort of building your first models and understanding how those are working. And then there are different tools like AppSheet where you can build an app that's like a form. So for example, if you wanted to do a questionnaire, or you wanted to sort of build a first sort of interactive chatbot, you could use these types of apps too. So I would have a look at what's out there, and don't let it be a barrier to you starting if you don't normally code. The things that you can do yourself are things like building a prototype. If you want to maybe build something for clinicians or patients to use, you can use something like Lovable to take you quite far towards having a prototype. It will be something that really looks like a functional app, and then you can get feedback. And I would say if you're building a tool, it's really important to get that feedback as you go along, because you can spend a lot of time building new features that your user doesn't really want. If you are doing something like an audit of your product, or an audit of your database, for example, to see where you might have gaps and issues, that's a great thing to use LLMs for example. Or just doing repetitive small tasks to save time. And creating internal dashboards for your team as well. That can all be done no code, I would say. Where you do need to be very aware of what your code is doing and get that checked and probably evolve it with a developer would be things that are making decisions about patient safety, decisions about prescribing, decisions about diagnostic advice, for example. Any model that you're going to have to regulate, or an app that's going to be subject to regulation because it's going to be used by a patient or in a clinic, or something that's going to be published. Anything that involves sensitive data, so things that will identify your patients would be sensitive data, for example. A validation that you need to back up. You need to have that done in a very sort of formulaic way. You can't have a sort of black box code. You need to know exactly what your code base does, what it doesn't do. And also scaling up to be able to deal with a lot of users. If you're creating a software tool or an app that you want to sort of roll out on a larger scale, you need to make sure that that is correctly built. So moving towards creating a project. So same project is done at the end of a course, and it showcases everything that you've learned. If you're on a sort of journey of self-learning and you are essentially creating a syllabus for yourself and learning new skills, then you may want to challenge yourself at the end of that project. Or you might be on, for example, a medical course where you need to do a capstone project anyway. That is typically a collaborative team project. And so there's just a quick bit to go through about how you might select that. So what makes a good capstone project is that you're showcasing your skills. So you want to be sure that you can finish it in the time frame that you have. You also don't want it to just be a signaling exercise. You want to answer a question that matters to you. Maybe you work in renal medicine, you want to ask a question about chronic kidney disease, and it's something that you've been wondering while you've been sort of in the course of your placement, for example. Something that irritates you or a colleague, or a question that you have about patient care or a condition that you actually want to explore. You have to be interested in what you're doing, and make sure that you have some data to look at as well. Often people say they're going to give you data. They take a lot longer to give you data than they say they will. So make sure you can access it. And also make sure that you can clearly answer a question. It can't be an open-ended question. You have to be able to answer that in the time that you have. And also decide what that positive result or negative result is going to look like, so that you don't have to later figure out if you've achieved that objective or not. If you are working in a team, the types of people that you might want to have taking responsibilities for different tasks would be one person leading the project who understands very clearly the ask, what is the problem and why are you doing it. Somebody that's going to take responsibility for data processing, which is probably a good half of the project. Data processing is very time consuming. It has to be done very correctly. So someone with some attention to detail. If you have someone on your team that has sort of coding skills and is able to work on the build of what you're doing, model, for example, and produce a prototype to show users, that person takes this builder role. And you also need somebody that's good at storytelling. So to people that may not be doctors, why you've produced what you have, what the results are, and presenting those in a way that makes sense. And who you pick for these roles really probably depends on person fit. Not all teams are able to have all of these roles filled, so you may have to put on some different hats and take different roles yourself, but that's all part of the learning process. So I would just encourage you all to start in a small way with looking at AI models, looking at tools that already integrate AI, looking at how you might integrate them into your practice, and looking at also understanding more if you are having to do things like read papers with AI and start looking at how you can critically assess them. But I would say definitely don't shy away from it. Maybe start in a small way, and talk to other people that have that interest in as well. The take-home messages I would share is that the validating a model and testing it in your setting is more important than what's being reported as the accuracy of that model in a different study. Getting your question right is really important to your research. You can use no code to get quickly to a prototype tool if you're interested in building your own tools. And there should always be a clinician final say to a model decision. So that's the end of my slides. I'm just going to come back to check the chat. If you have any questions, please do leave them in the chat.
Yes, Sid, I think there are some questions on the chat box. You can just go through.
Yeah, sorry, let's go up to the top. On the topic of healthcare data, Okay, this is an interesting question. Digitalizing paper records. There are OCR models that specialize in that task of reading in paper notes and turning them into typed notes so that those can be scanned by other models. I would look into OCR models. There are some available, I think, from Google, for example, but definitely on Hugging Face, you'll find quite a few of those as well. That's, I think, a really useful challenge that will be relevant to a lot of different settings, actually. In healthcare, a model that's technically accurate can still be used if it erodes trust. Yeah, how do we get over that hurdle of getting models to actually be used at the bedside? So I will tell you that in the UK, to get a piece of software, including AI, into an NHS trust, which is their public medicine provision, it takes about 7 years. It's very resistant to taking in new pieces of software and new technology. So trust building is just a huge part of acquisition into clinical context in a way that I don't think it is in any other field. If you can find a clinical champion, so if you can find someone that's more senior on the medical staff that likes what you're producing and understands how it will save time and benefit patients, then that can take you a long way. But also talking to the hospital directly, finding out what their main challenges are and trying to align with their challenges, I think is important. In terms of how we balance the different measures of success of a model, I don't think actually that the performance of a particular model is hugely influential to that technology being adopted, as opposed to sort of explaining the process of the tool and how it can support clinical pathways. I think that that is much more influential. What are the biggest challenges in deploying AI-powered remote diagnostic tools? And can they be addressed given limited internet access and infrastructure? That's also a very good question. You know, how do we not increase inequality in healthcare provision with AI? It's something that should be a leveler, but we need to deploy it in a way that it does actually benefit those who are already disadvantaged. So I think in the more rural areas where there is limited internet access and there are probably lower tech phones, we find that most people still do have some form of mobile access, even if it's shared. So I think creating things along the sort of M-Pesa model, where it's like a very simple, lower tech form, but it's still accessible and useful, I think that's important. In terms of remote diagnostics, I think there's also the element of cost. You know, there needs to be some sort of interaction with funding bodies to be able to cover the costs for people that already can't afford healthcare. Potentially they have the same barriers to accessing remote healthcare if they still have to pay for the app service. So there has to be a payment structure in place, I think, that's also going to support the use of those tools. Otherwise, it's a huge challenge. Am I currently working on predictive models in Africa or automating processes, chat boxes? Yes. So I work also as a CTO for a company called Health Equity Chain, and their focus is on reducing health inequality by using AI to focus on things like, for example, diagnostics with iron skin conditions in the field, how that is possible. So yes, there are current contexts, and if you are interested in working with us, you know, please contact me after the talk via my LinkedIn or via my email. Which AI diagnostic tools are being deployed in African clinics right now? I'm not sure over the whole of the continent what is most prevalent. Within the clinic, it's a good question. Probably things like AI scribes are the most popular, I would say. Also things like AI models for scanning chest x-rays, for example. There are a few of those in deployment. Imaging processing is a big aspect that I didn't really touch on much, but being able to find features in image conditions like CT scans, I think is that there's an application for that currently. How effective are SMS-based AI interventions compared to smartphone outputs in low bandwidth settings? I would say they are the only ones that have the potential to be effective if there is issues with low bandwidth and there's not much of a smartphone rollout. There are obviously areas where there is a lot of disparity in the type of technology that individuals will have even within that one area. So and there are potentially different audiences for smartphone app users that are potentially more lucrative financially because they're associated with private healthcare, for example. You are currently a software engineer. How about someone who wants to go into health tech but isn't a software engineer? I would say it's actually much more important that you have a clinical background and understanding of health data to come into health tech than it is that you're a software engineer. I think you can easily pair up with somebody that is a software engineer and has that side of things. But if you're a software engineer, it's much harder to gain an understanding of healthcare because healthcare is so broad. Let's see. How far is the application of AI in biomedicine and drug discovery? AI is really taking off in drug discovery. It's very big. It has very broad applications there. So that is definitely a space to watch. How can sensor noise be filtered or reduced such that the actual data can be gotten during data transmission in wearable technology? Yeah, that's interesting. So there are fixed high and low filters that we can put on. There are things like Kalman filters. There are all sorts of ways in which we can filter data in real time and give people very fast feedback. And then sort of on top of that, when we're model building, we can have different ways of refiltering and labeling if we're then building a machine learning model. Yeah. Yeah, how can we achieve sort of simplicity? I think that the best sort of development of these type of tools always involves as much simplicity as possible. So I think there's no benefit to having unnecessary complexity in either models or in tools. I think if you can get to the heart of what's required and keep it simple and provide that in an accessible way, then that is really an important skill to have. What is my view on text-based full models? I think that I already mentioned that it depends on the context, whether we should use TensorFlow. I think is hugely useful if you are a coder. What are the biggest challenges in deploying? I think we've had that one already. Which workflow tools and methods can work in 2026? So in terms of, if you mean in terms of sort of AI automation of your existing clinical workflows, I think things like Zapier and N8N are very useful if you're not a coder. If you are a coder, probably using something like LangChain to chain lots of small models doing individual small tasks. I would start small by looking at one model that can do one task, one part of a chain of a workflow, and then progressively connecting those together to replace the things that take you the most time, starting with the thing that you find takes you the most time or is the most annoying within your workflow. How do we ensure we test the tools enough to avoid disruption of mental health? Yeah, that's a really good question. How do we test mental health models with real patients without causing them distress in using that tool? That's a really excellent question. I think that that potentially the first line of testing often is with somebody that's simulating a mental health user rather than someone that is actually a patient. There's quite an extensive round of testing like that before it's ever tried with patients, and it generally would be deployed in a supervised way, parallel to them receiving their normal treatment. So they're always with a therapist, for example, when they're using that app. Can the assembled data lead to failures with varying geography? Yeah, absolutely. Even just transferring between one group of patients and another in the same context. If the differences between those different data sets haven't been considered properly, and there's often a lot in data that we don't understand, the differences between different patient data sets. So there are lots of different causes of the same disease, for example, that might cause patients to respond differently in different settings. So definitely we need to be suspicious and be retesting and be reevaluating every time that we're moving a model from one setting to another setting. Who reviews alerts and in what time? Can I audit the model reasoning? Yeah, absolutely. We can alter the model reasoning. So if it's something like a large language model and we've given it a prompt and a constraint and we've given it rules, we should be auditing and reevaluating that. You know, each time we increase the number of users, or each time, you know, some time has passed and we have some longitudinal data. Because your first model, especially if you're using it in a clinical tool, you probably won't have that many real users to have data from. So you need to keep reevaluating as your data set grows to make sure that it's actually serving your users, probably after you do your. Is there a specific value or range of values for precision used? So there are the different metrics that I mentioned before. If you mean, is there a specific data set, there are benchmarking data sets that are available specifically for training models that we can access that are public available. So it would be good to look into benchmarking data sets. If the vendor shuts down tomorrow, do I still have access to the data and the model? That's an interesting question. So you mean in the context of you're using an app? And that did happen actually with a shutdown, that all data would be lost. They should still have access to request amount of time after a vendor is shut down. The model may or may not be disclosed, depending on whether the vendors decided to make that open source or not. How can one possibly join or start research related to AI healthcare innovation, because I can't possibly start on my own? I would say that you definitely can start on your own with a concept. And you can start to talk to other people about that concept that are also excited in the same space. I would try and find maybe a co-founder or another person that's interested in building what you're doing, somebody that understands the problem that you have and the reason for building that product. And maybe start with sort of patient groups, other clinicians working in that space, and identify other people with that interest. But you can definitely start something on your own, and you don't have to be a coder. You don't even need to be a doctor, I think, just to have the interest, and you can get started in a low code way. Let's see. Is there a way to apply AI in microbiology studies? Yes, there is. We can use AI to do things like identifying and assessing cells, for example. Also, machine learning models can be applied to, you know, almost any type of studies where we have enough data. I know that we're soon about to run out of time. So do we have any questions that I haven't covered? We probably do. Please feel free to email me or connect with me on LinkedIn after the call if you do want to send me any questions directly. And I'll also share my slides as well. See. Oh, my LinkedIn link. Let's see. See if I can do that in time. Sorry, I'm just looking for my link to share with you.
Okay.
Okay, this is my LinkedIn if anyone would like to connect with me. And thank you all for attending and for your questions as well.
Yeah. So thank you so much, Hida, for this. So I think there were lots and lots of questions. We don't have enough time to attempt all of that. So Hida already sent her LinkedIn URL on the chat box, so you can just shoot her a connect and ask her a question if you have any. And I think she mentioned something about if you have interest working with health APT chain, you can reach out to her also on LinkedIn. So, and to be honest with you, she's open to conversations, right? I think she's one person that I know that I can reach out to at any time and have a conversation with on things. So thank you so much, Hida. Let's go
You're
ahead
very welcome.
and give a round of applause just with any emoji. I love whatever emoji that comes to mind. Thank you so much. This
Thank you,
was quite
everybody.
impactful. We really appreciate this.
Thank you.
So thank you so much, everyone, for
Bye.
connecting this evening, this morning, this afternoon, from wherever you're connecting from. So we'll continue tomorrow. Tomorrow is going to be powerful. My boss is coming tomorrow. So tomorrow is going to be powerful. Today was superb. Tomorrow is going to be something else.